Hi everyone, welcome back to Mohivate. I'm Dr. Mohi Sarawgee, a GP by profession, but here I'm swapping prescriptions for perspective. It has been quite a month in women's health. This week, a major international proposal published in the Lancet on 12th of May recommended renaming PCOS to PMOS, polyendocrine metabolic ovarian syndrome, a name that finally reflects what this condition actually is. We will discuss it properly on Mohivate, but today we have something equally timely. Today we are talking about a very specific ongoing viral trend. Women on social media combining an antihistamine and a heartburn tablet and reporting that it is transforming their menopause symptoms. The trend comes from the US. CNN covered it, ABC and Good Morning America covered it, Fox and Yahoo Health covered it, all within 48 hours of each other. And thankfully, BBC hasn't. After the panorama situation, we will give them a pass. In the US and in many countries, both these medications are available over the counter. In the UK, however, the heartburn tablet at the center of this trend is prescription only, which makes it even more interesting that it has begun to appear on patient lists in GP surgeries requested by name by patients who found it online. And as any GP will tell you, when that happens, it is time to have the conversation properly. Now, this is the first time we are discussing menopause on Mohivate, and I should tell you, I have a keen interest in perimenopause, menopause, and andropause. This subject will have many episodes of its own. But before we get into the trend and the science, let me introduce you to menopause the way it was once memorably described. The late Suzanne Summers, actress, author, and one of the most honest voices on women's health of her generation, described menopause through what she called the seven dwarfs. The dwarfs have been updated many times, but the original seven were these: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and all dried up. Now, if Suzanne Summers could name the dwarfs of menopause, I think on Mohivate we can name the dwarfs of andropause too, the male hormonal pause, because some of the men listening right now who feel quietly seen by at least three of those dwarfs, that episode is coming, I promise. And one of those dwarfs deserves a special mention before we go further. Forgetful, because brain fog, the difficulty concentrating, the words that disappear mid sentence, the feeling that your mind is wrapped in cotton wool is one of the most distressing and most under-acknowledged symptoms of perimenopause and menopause. And it is one of the key reasons women have been turning to this viral trend. So let's start with exactly what is going on. The viral protocol involves one antihistamine, typically fexofenadine, sold as Allegra, or cetirizine, sold as Zyrtec, combined with famotidine, an H2 receptor blocker, and heartburn medication sold as Pepcid in the US. The viral trend suggests taking both together daily for menopause symptoms, specifically hot flushes, brain fog, skin itching, joint pain, and sleep disruption. And before I give you the clinical verdict, I want to say something that matters to me as a GP. The women who found this trend and tried it are not foolish. They are women who have been symptomatic, who have felt dismissed, and who took matters into their own hands with what appears to be a biologically coherent rationale. That deserves respect, not dismissal. Women's health has been chronically understudied. Menopause research has been chronically underfunded. The vacuum that creates is filled inevitably by social media. And when medicine leaves a gap, the internet will always find a way to fill it. So the question today is what the science actually says. And to answer that, we first need to talk about histamine. You have heard the word. When most of us hear histamine, we think allergies, food allergies, hay fever, and the tablet you take before you visit someone with a cat because you love them, but not that much. That association, allergies, hay fever, sneezing is not wrong, but it is deeply incomplete. Histamine is one of the most versatile chemical messengers in the entire human body. It acts as an immune signal, a neurotransmitter, a gastric acid regulator, and a vascular modulator. Allergies are just one chapter of a much longer story, and it works through four different receptors: H1, H2, H3, and H4, each one doing something completely different. The ones that matter most for today's episode are the first two, H1 and H2. Let's start with H1 receptors. These are found in your blood vessels, smooth muscle, and the brain. Think of receptors as locks on the surface of your cells. Histamine is the key. When your body encounters a trigger, an allergen, an infection, certain foods, or even stress, specialized immune cells called mast cells release histamine into the surrounding tissue. When histamine fits into an H1 receptor, the lock opens and triggers a response. In the body, that response is what we recognize as a classic allergic reaction: itching, runny nose, swelling, vasodilation, which is why your skin goes red and puffy. And in more severe cases, the kind of reaction you see in urticaria, where the skin erupts in angry, itchy welts or hives, as most people know them. But H1 receptors extend beyond the body. They are present in the brain too. And in the brain, histamine binding to H1 receptors does something completely different. It promotes wakefulness and alertness. Histamine is part of your brain's arousal system. It literally keeps you awake. H1 receptors in the brain are also involved in cognition, memory, circadian rhythm, and anxiety, which means when histamine signaling in the brain is disrupted, cognitive symptoms can follow. File that away. It becomes important very soon. Now, the medications we commonly call antihistamines, loratadine, cetirizine, fexofenadine, chlorphenamine, are technically H1 receptor blockers. They work by sitting in that lock before histamine can. No key, no response, no sneezing. And they come in two generations. The first generation, chlorphenamine, commonly known as Piriton in the UK, and diphenhydramine, sold as Benadryl, are sedating. They cross the blood brain barrier and block H1 receptors in the brain, switching off your wakefulness signal. They are not making you sleepy as a side effect. That is the effect on the wrong receptors. The second generation, cetirizine, fexofenadine, loratadine, were designed with the hope that they would stay out of the brain. And here is a fascinating detail confirmed by PET imaging studies. Fexofenadine was shown to not occupy a single H1 receptor in the brain, which is why it is officially classified as non sedating. However, and this is a clinical nuance worth knowing, many patients still report feeling drowsy on fexofenadine, particularly at the 180 milligram dose. The science says non sedating. The patient in front of you may disagree. And in medicine, both things can be true simultaneously. Cetirizine, however, was shown to occupy around 30% of brain H1 receptors in those same imaging studies, which is why drowsiness is more consistently reported on it. Not all second generation antihistamines are created equal. Now, H2 receptors. They are found primarily in the stomach lining where they stimulate acid production. Your stomach needs acid to digest food and protect against bacteria. Useful in the right amount, problematic when there is too much. When histamine binds to H2 receptors in the stomach, acid production increases, which is exactly why, in conditions like acid reflux, heartburn, and peptic ulcers, we use medications that block this receptor. Less histamine signaling, less acid, less burning. The most commonly used H2 blocker in this viral trend is famotidine, sold as Pepcid in the US available over the counter in many other countries, and available on prescription only in the UK. It sits in the H2 lock before histamine can, and as we are about to discover, potentially something else entirely when taken alongside an H1 blocker. H2 receptors are also found in the heart, where histamine can influence heart rate, and in the brain, where they contribute to cognition and alertness, which means both H1 and H2 receptors have a presence in the brain. Both are involved in cognitive function, and both are being blocked simultaneously by this viral combination. Keep that thought too, because it matters. Two medications, two receptor types, one molecule at the center of it all. So, why would any of this have anything to do with menopause? To answer that, we need to talk about estrogen. The two hormones at the center of the menstrual cycle, perimenopause and menopause, are estrogen and progesterone. Estrogen drives the reproductive cycle, maintains bone density, protects the cardiovascular system, and regulates mood. Progesterone works alongside it, rising after ovulation each month, preparing the body for pregnancy and helping to stabilize the cycle. Together, they rise and fall in a predictable rhythm throughout the menstruating years. For anyone who has menstruated through their life, as they age, both hormones begin to decline, but they do not decline smoothly or simultaneously. Progesterone tends to drop first. Ovulation becomes inconsistent. Some cycles happen, some do not. And without ovulation, progesterone is not produced. Estrogen follows, but not in a straight line. It fluctuates. Some months high, some cycles barely there. This unpredictable fluctuation is perimenopause, the transitional years before the final period, and eventually estrogen falls and stays low. That is menopause. Now, apart from everything estrogen does that we already know about, it has a relationship with histamine that changes everything about how we understand perimenopause symptoms. Here is how it works. Estrogen is actually a family of hormones. The most active and most relevant form is called estradiol, and that is the one we are talking about today. Estradiol stimulates mast cells to produce and release histamine. Mast cells are your immune system's first responders. Estrogen is one of their activators. Histamine, in turn, stimulates the ovaries to produce more estrogen, and it does this through H1 and H2 receptors, the same ones we just discussed. These receptors are present on ovarian cells too. So, estrogen makes histamine, and histamine makes more estrogen, a feedback loop, each one driving the other. Think of it like two colleagues who keep forwarding each other's emails endlessly, neither one quite sure who started it. Under normal cycling conditions, when estrogen rises and falls predictably and progesterone provides its counterbalance, this loop stays relatively controlled. But during perimenopause, the transition years before the final period, estrogen stops cycling predictably. It fluctuates wildly, some months high, some months barely there. Progesterone has already started to fall, and this loop loses its rhythm. It lurches between overactivation and suppression. The histamine signal becomes erratic, and an erratic histamine signal, as we have just learned, has consequences across the body and the brain. And there's one more piece to this story. Histamine does not just get released and stay in your system forever. Your body has a mechanism to break it down and clear it. The primary enzyme responsible for breaking down histamine is called diamine oxidase, or DAO. Think of DAO as your body's histamine clearance system, the cleaner that comes in after the signal has been sent and tidies everything away. It is not the only mechanism the body uses to manage histamine, but it is one of the most important ones. Now, Estrogen helps regulate DAO activity, which means when estrogen drops, DAO activity can drop with it. Less clearance, more histamine accumulating in the system, the cleaner stops showing up, and the histamine already being produced erratically in perimenopause because of the feedback loop we just discussed now has nowhere to go. The result, and this will resonate with many women listening, allergies can change dramatically around perimenopause. Some women who never had hay fever suddenly develop it in their 40s. Some women find foods eaten for years, red wine, aged cheese, processed meats, fermented foods, suddenly cause flushing, headaches, or bloating, skin reacting to things it never did before. All of this can be histamine related, the immune system joining the hormonal chaos. Is this the whole story of perimenopause? Absolutely not. But the histamine connection is real, it is biologically grounded, and this is the foundation on which this viral trend was built. And one more thing worth saying, this trend did not come from a doctor's office. It came from women sharing experiences in online communities. And that context matters. But you can now see the logic behind it. If estrogen disrupts histamine regulation, if the feedback loop becomes erratic, if DAO stops clearing histamine efficiently, then blocking histamine receptors seems like a reasonable response. Block H1 with an antihistamine, block H2 with famotidine. Less histamine signaling, potentially less hot flushes, less brain fog, less itching. The logic is not completely unreasonable. The question is whether the evidence supports it. And that is where things get more complicated. And for some women, there may be something more specific going on, a condition called histamine intolerance. This is different from allergies, different from full mast cell activation syndrome. Histamine intolerance occurs when the body cannot break down histamine efficiently, usually because DAO enzyme activity is chronically low, not a dramatic immune reaction, just a slow accumulation that the body cannot clear. Symptoms of histamine intolerance include headaches, flushing, skin itching, heart palpitations, digestive symptoms, and brain fog. Sound familiar? They overlap significantly with perimenopausal and menopausal symptoms. And because perimenopause can reduce DAO activity, it can reveal a histamine intolerance that was always present but never loud enough to be a problem until now. For this specific subset of women, blocking H1 and H2 receptors may genuinely help, not because it helps with menopause, but because it addresses a separate, overlapping condition that perimenopause has brought to the surface. This may be why some women feel better on this combination. And this distinction matters enormously. The mechanism is real, but it is not the menopause mechanism being claimed on social media. And without proper clinical assessment, you cannot know whether you are in that subset. Taking it based on a TikTok caption is not the same as a diagnosis. So, let me give you my honest perspective. Does this combination work for perimenopause or menopause? Here is my honest answer. There are no randomized controlled trials of this combination in menopausal or perimenopausal women, not even observational cohort data. What exists is a hypothesis, a biologically interesting hypothesis built on real science about estrogen histamine crosstalk, but a hypothesis nonetheless. The viral H1 plus H2 combination appears to have been borrowed from the treatment of mast cell activation syndrome, MCAS, a condition where mast cells are abnormally and repeatedly triggered, releasing histamine and other inflammatory mediators in unpredictable ways. In MCAS, combining H1 and H2 blockers is an established approach endorsed by clinical guidelines. And some women with MCAS do experience menopause like symptoms as part of their condition, which is likely where this idea first emerged. But MCAS is a specific diagnosed condition. It requires elevated tryptase or histamine metabolites on testing alongside a demonstrated clinical response to treatment. It is not the same as perimenopause, and what works in one context does not automatically transfer to another. And here is the most important clinical point: the primary driver of menopausal hot flushes is not histamine. It is a completely different pathway. The hypothalamus, your body's thermostat, loses the moderating influence of estrogen on a group of neurons called KNDY neurons, which releases a neuropeptide called neurokinin B. Overactivation of these neurons triggers the cascade that causes a hot flush. This is why the newest non hormonal medications specifically developed for menopause target the neurokinin B receptor, not the histamine pathway. The thermostat problem is a neurokinin B problem, not a histamine problem. And brain fog, that dwarf we named at the start, is driven primarily by estrogen's direct effects on the brain, not by histamine pathways. Two medications have now been licensed specifically for this neurokinin B pathway. Fezolinetant, licensed in the UK in December 2023, now supported for NHS prescribing as of March 2026, and elinzanetant. The UK was actually the first country in the world to approve it in July 2025. Both are non hormonal. Both have proper randomized controlled trial evidence. Both are designed for exactly this problem. And the placebo response rate in menopause symptom trials is consistently high, between 30 and 40%, which means some of what women are experiencing as improvement may be real but driven by expectation rather than pharmacology. So, does this viral trend work for menopause? For most women, the evidence does not currently support it. For a specific subset, those with underlying histamine intolerance or mast cell features that perimenopause has revealed, there may be genuine benefit. But without proper assessment, you cannot know which one you are. And the women trying this deserve better than a guess. And yet, every day, women are trying it. And I understand why. I hear you. I genuinely do. We live in a strange moment in medicine where your doctor didn't tell you this has become its own content genre. But here is what I find fascinating and a little uncomfortable as a GP. The same person who reads every side effect on a prescription label 3 times with reading glasses, cross referencing Google, will find a trending medication combination on social media and start taking it that evening without a single question to their doctor. We fear the known. We are oddly comfortable with the unknown as long as it comes with a good caption and 1,000 comments saying, "Me too." This is not unique to menopause, it is human. We fear the side effects of the known far more than the cost of quietly doing something unmonitored that nobody knows about. But here is what I want you to hold. Your body is not a social media experiment. Your hormonal transition is not a hack. You deserve a proper conversation with someone who knows your history, your medications, and what you actually need. And as I have said before on Mohivate, social media is a wonderful place. It is just not a clinic. So if you are already taking this combination or thinking about it, here is what you need to know. Antihistamines are not completely without side effects. Drowsiness, dry mouth, effects on concentration, even with second generation antihistamines, as we discussed. And here is something that almost nobody is mentioning in the social media conversation. In 2025, the FDA issued a warning that cetirizine, after long term daily use, can cause severe rebound itching if stopped suddenly. Not a reason to panic if you're taking it, but a reason to taper gradually rather than stop cold. Famotidine reduces stomach acid, which means it can affect the absorption of certain medications that need an acidic environment to work. Antibiotics, antifungals, some heart medications, iron supplements, and it needs dose adjustment in kidney impairment. That is exactly why the conversation with your doctor matters. And the biggest concern, the one I feel most strongly about as a GP, is delay. Women who find relief from this combination, whether genuine or expectation driven, may delay seeking evidence based care. And that delay has real costs to bone density, to cardiovascular health, to quality of life. So, what actually works? Hormone replacement therapy, HRT, also called MHT, remains the most effective treatment for menopausal symptoms. The conversation around HRT has shifted significantly in recent years. For most women, in the right context, the benefits outweigh the risks. If you have been avoiding it based on something you read or were told years ago, that conversation is worth having again with your GP first. And if you need more support, menopause specialists exist in most countries now. You're allowed to seek it. For women who cannot or choose not to take HRT, non-hormonal options with proper clinical trial evidence now exist. Non-hormonal does not mean no options. And lifestyle, exercise, nutrition, sleep hygiene, and cognitive behavioral therapy when needed. These are not consolation prizes. They have evidence, they work. And if at times you have not felt heard, keep going until you find someone who does hear you, because many doctors like that exist, and you deserve that conversation. So here we are. A heartburn tablet and an allergy pill went viral. And behind the trend, there is genuinely interesting biology. A real and bidirectional relationship between estrogen and histamine. A plausible mechanism for a specific subset of women, particularly those with underlying histamine intolerance or mast cell activation features that perimenopause may have brought to the surface. But a plausible mechanism is not clinical evidence, and a comment section is not a randomized, controlled trial. What I hope you will take from today is not a verdict, it is something simpler. Your symptoms are real, your frustration is valid, the gap in women's health research is real, and you deserve to be heard and to be treated by a medicine that takes all of this seriously. I hope something today stirred a thought, gave you a smile, or simply made you feel a little less alone in this. Thank you for listening. I'm Dr. Mohi. Until next time, remember this. Your body is not broken. It is communicating. And sometimes learning to listen with curiosity instead of fear is the first step back to coming home to yourself.